Aparna?
Yes,
Am
ma'am.
I audible?
Yes, ma'am.
Right. How many of you in the class? What's the total strength?
Ma'am, 135 ഉണ്ട് 100 Zoom-ൽ കയറും ബാക്കി YouTube-ൽ കയറുന്നുണ്ട്.
And the YouTube കയറാൻ Zoom കയറാൻ എന്താ പ്രയാസം?
Zoom-ൽ 100 maximum limit ഇട്ടിട്ടുണ്ട് ma'am.
Okay. Right. Shall we start off with the class?
Yes, ma'am.
Tell me if my slides are visible, okay? Is my slide visible?
No, ma'am.
No. Give me 1 minute, okay? Hello. ഞാൻ ക്ലാസ്സിലാണ് പിന്നെ വിളിക്കണം. My screen visible now?
No, ma'am.
Not yet?
Yes, ma'am. ഇപ്പൊ visible ആണ്.
Okay. Right. So the topic for today is primary amenorrhea. I expect an interactive session with you because the topic is slightly boring. That's the reason. So I would appreciate if you ask questions in between, interrupt me in between, and try to grasp the bare minimum which is needed in this topic for you. It is actually a difficult topic, but as far as undergraduates are concerned, you will have to know a few aspects about primary amenorrhea, which we will discuss in detail now. Okay. So how do you define primary amenorrhea? So what is amenorrhea? Absence of menstruation. So primary amenorrhea is menstruation which has not at all started. So if there is absence of menstruation by 14 years in the absence of secondary sexual characters and 16 years in the presence of secondary sexual characters, you would call it as primary amenorrhea. So primary amenorrhea is basically something with delayed puberty or with normal puberty. So suppose a girl comes to the OPD saying that she has not attained menstruation, and when you examine, you find secondary sexual characters, then probably you could ask, hello? Yes? Any problem? Can I continue?
Yes, ma'am.
With delayed puberty, and if the girl has secondary sexual characters, probably you could wait up to 16 years to start off with the evaluation. But if there are any characteristic features, then I don't think you should be waiting till 16 years. You have to start off with the treatment early. So in order to understand about amenorrhea, you should know something about the development of the testis and the ovary. We all know that the presence of the SRY gene in the Y chromosome determines the development of the testicles. So in the absence of this Y chromosome, by default, the gonad becomes an ovary. So if there is an SRY gene in the Y chromosome, the gonads develop into testicles. And if there is no Y chromosome, whether there is an X chromosome or not, if there is no Y chromosome, the gonad becomes an ovary. Clear? And also, the important thing which you should realize is that there are two X chromosomes are needed for an optimal ovarian development. And suppose there is an absence of the second X chromosome, the ovary may be devoid of its oocytes. So again, looking into the physiological changes of puberty, you have the growth spurt, the breast development of the thelarchy, adrenarchy, that is the pubic hair, and then you have the onset of menstruation, which you call as menarche. So or you can note that from this graph that breast development and linear growth occurs almost simultaneously, around 10 to 11 years, and pubic hair development starts, the adrenarche part starts developing around 11 years, and usually menarche is around 13 to 14 years of age. Again, if you were to measure the sexual maturity rating, you use something known as Tanner's staging for that. Have you heard about it? Have you heard about it? Somebody respond. Tanner's staging? ഇല്ലേ ആരും? അപർണ, ലക്ഷ്മി?
മാം കേട്ടിട്ടില്ല.
കേട്ടിട്ടില്ല. Okay, so the sexual maturity rating is done by something known as Tanner staging. So everything has a very much, what is normal for me may not seem normal for you. So for that, we have something in a more structured way, which we stage using this method, the Tanner staging method, sexual maturity rating stage using Tanner. So here you have something known as stage 1, stage 2, stage 3 for the pubic hair. You can see from this picture that the stage 1 is infantile genitalia, and stage 2 you have a little bit of downy hair, and in stage 3 slightly darker and coarser hair, and stage 4 becomes more resembles more of the adult type, and stage 5 is the adult type of estrogen and distribution of hair. Looking into the breast development, stage 1 is infantile, there only the breast papilla is seen, and stage 2 there will be a small breast bud developing. Stage 3 there is more rounded contour developing. Stage 4 the small breast will be developed, and breast stage 5 of thelarchy is again the normal adult appearance. So if you were to look into the causes of primary amenorrhea, you have an umpteen number of causes. But for all practical purposes, when we look into undergraduate level, you should understand that primary amenorrhea is equal to one anatomical causes, as in the case of imperfect hymen, or if there is no sexual character, secondary sexual characters, you have to think about Turner syndrome, and you have to think about Mayer-Rokitansky syndrome, or what the other condition which you should know is the androgen insensitivity syndrome. So 4 important things you should always keep in your mind when you think about primary amenorrhea in the case of an undergraduate level. Okay, in fact, even for postgraduates, that's the most important thing you should understand. So if you look into the hypothalamo-pituitary causes, there are congenital causes and acquired causes. The congenital causes will be isolated GnRH deficiency, multiple pituitary hormone deficiency, the acquired ones being hydrocephalus, secondary to infections, trauma, empty cellular syndrome, tumors, functional hypothalamic amenorrhea as in anorexia nervosa, exercise and stress, the ovarian dysgenesis as in Turner syndrome and its variants, XX and XY gonadal dysgenesis. In the uterus, you have uterovaginal agenesis, menstrual flow obstructions. Adrenal, you have congenital adrenal hyperplasia and androgen secreting tumors. In thyroid, it's pubertal, prepubertal or juvenile, and others the androgen insensitivity syndrome, 5-alpha reductase deficiency. And of course, you should not ignore the fact that there is a constitutional delay, because there are families in which the puberty is generally delayed, and prior chemotherapy and radiotherapy. So these are some of the list of causes of primary amenorrhea which have been listed here. Clinically, if we were to classify primary amenorrhea, we would say that primary amenorrhea is one with the normal secondary sexual characters. The second one is the absent secondary sexual characters, and the third one is the heterosexual development. So we'll start off with primary amenorrhea with normal secondary sexual characters. So as I said, primary amenorrhea definition that is 16 years of without menstruation, the presence of secondary sexual characters, and if there is no secondary sexual characters, you have to think about at 14 years, which does not mean that if a girl comes to you with cyclical abdominal pain and at 12 years of age and she has normal secondary sexual characters, you don't have to 16 years to tell. Am I getting disconnected? Basil, ഉണ്ടോ ഇവിടെ ക്ലാസ്സില്? പിള്ളേരും മിണ്ടാത്തത് എന്താ? Okay, Basil Thomas, can you define primary amenorrhea? Basil attendance mark absent mark ചെയ്തേക്കണേ. Femina, can you define primary amenorrhea? Kartika, he answer.
Hello, ma'am. Hello, ma'am.
Ah.
Ma'am, the girl has reached 16 years but still having no menstruation, but she is having all the secondary sexual characters.
Who is saying this?
Kartika.
Okay. So ഫെമിനിക്കും ബേസിലും അറ്റൻഡൻസ് മാർക്ക് ആബ്സെന്റ് മാർക്ക് ചെയ്യണേ. വെറുതെ കമ്പ്യൂട്ടർ ഓൺ ചെയ്ത് വെച്ചിട്ട് അവർ എങ്ങോട്ട് നടക്കാൻ പോയിരിക്കുക കേട്ടോ. So clinical classification of primary amenorrhea with the normal secondary sexual characters and absent secondary sexual characters and heterosexual development. So as we said, we define primary amenorrhea. We also said that it is the Y chromosome which decides whether the gonads develop into a male pattern, and if there is no Y chromosome, by default it becomes a female type of development. Okay, so we look into the primary amenorrhea causes with normal puberty. That is, the girl has all the secondary sexual characters, and most often it is anatomical defects. What are the causes which we generally see is cryptominority, Mullerian agenesis, androgen insensitivity syndrome. Polycystic ovarian syndrome is an extremely rare cause of primary amenorrhea. Most often it presents with secondary amenorrhea. Then hypothalamic dysfunction as in severe weight loss, extreme exercise, psychological stress, and endocrine causes like hyperprolactinemia. Again, as I said, the causes 4, 5, and 6 are more often associated with secondary amenorrhea than with primary amenorrhea. How do you make a diagnosis? The girl presents to the OPD with the absence of menstruation. You do an ultrasound scan. If there is a presence of uterus, you know, how do you assess for the presence of uterus? You can either do a rectal examination and feel for the body of the uterus, or you can do an ultrasound to look for the presence of uterus. If the uterus is absent, you have to think about Mullerian agenesis or androgen insensitivity syndrome. And how do you differentiate between these two? By doing a karyotype. In the case, if the karyotype is XS, it is X and X, it is 46XX, it is Mullerian agenesis. And if the karyotype is X46XY, it is androgen insensitivity syndrome. So we will look into cryptominorrhea. What is cryptominorrhea? This is a regular short essay question for you. It comes for 4 marks. Generally, the causes of cryptominorrhea. Crypto means concealed menstruation. Okay. So cryptominorrhea is blood collecting inside the vagina. Okay, so that is hematocorpus. That is not revealed menstruation, cryptomenstruation. So imperfect hymen, transverse vaginal septum, vaginal agenesis, all these are some of the causes of cryptominorrhea. So the girl has normal secondary sexual characters. It has a normal intact hypothalamo-pituitary ovarian axis. But what is the problem? The outlet is having an obstruction in the form of either an imperfect hymen or a transverse vaginal septum, or it is because of vaginal agenesis, for which reason the uterus, which sheds the menstrual blood, is not able to escape outside and it collects inside, causing something known as cryptominorrhea. And the girl typically presents with recurrent episodes of cyclical abdominal pain. And when you palpate the abdomen, you may get a suprapubic bulge. And locally, when you examine, in the case of an imperfect hymen, you may see a bulging bluish hymen. Whereas in the case of a transverse vaginal septum, and especially if the septum is very thick, the bulge may be pinkish in color. Higher obstructions, you may not get a bulge at all. So this is the picture of a imperfect hymen. Here you can see very clearly the dense bulging bluish membrane of this girl, and there she has a suprapubic bulging mass also. And when we do an ultrasound scan, you can notice that there is a large collection. This is the bladder, and there is a large collection of blood in the vagina just behind the bladder, which is suggestive of the hematocolpos. So this is the hematocolpos which is being measured here, almost 12 centimeters in length. You can see. Am I clear? You want me to repeat
Yes,
it? So imperfect hymen. How do you diagnose imperfect hymen? By local examination, you notice a dense blue bulging membrane. And when you do a per rectal examination, you get a bulging cystic vagina anteriorly. When you do an ultrasound, you can notice that there is collection of blood in the vagina, which you call it as hematocolpos, and there may be collection because of the back resistance. There will be collection of blood inside the uterus, which is known as hematometra. So how do you treat this condition? The treatment is by putting a cruciate incision on the hymen. And when you put a cruciate incision into the hymen, tarry blood which is collected inside the vagina and the uterus start escaping. Remember, at this situation, you are not supposed to give any abdominal pressure in order to make all the blood come out. You should allow the blood to come out on its own, because by giving abdominal pressure, you're going to cause regurgitation of the blood more into the abdominal cavity. So just leave it like that. The blood slowly escapes. And no vaginal examination should be done at this point of time, because by doing a vaginal examination, you are only going to introduce infection. You may give a slight raise in the head of the bed, and antibiotics should be given. And you should follow the girl for looking for any residual pathology. Other conditions which can cause cryptominorrhea are agenesis, failure of vertical fusion of the vaginal septum, failure of lateral fusion of the vaginal septum, and these etiology are always polygenic, maybe multifactorial, involving teratogens, environmental causes. The pathology of Mullerian malformation is a failure of formation of the vaginal plate due to failure of canalization, cavitation. Okay, so actually, in Mullerian malformation, there are two Mullerian ducts which fuse and form a vaginal plate, and this vaginal plate has to canalize to become the vagina. If this does not, failure fusion can occur or failure of canalization can occur. In all these conditions, there are vaginal maldevelopments and septum formations. So vertical fusion defects is failure of fusion of the Mullerian system or urogenital sinus, or segmental canalization of the vagina, and lateral fusion defects are failure of fusion of the two Mullerian ducts, that is the two UV canals, which may be obstructive or non-obstructive. Transverse vaginal septum is again faulty fusion or canalization of the urogenital sinus and the Mullerian ducts, which is seen 45% in the upper vagina, 40% in the mid vagina, and 15% in lower vagina. All these are not so very important for you, but remember, vaginal anomalies, vaginal agenesis, vaginal maldevelopment can always present with cryptominorrhea, along with imperfect hymen. What are the investigations required? Ultrasound is the most important investigation which is required in this situation, which shows you hematometra, hematocolpos. Always remember, when there is an anomaly in the lower genital tract, you may have associated urinary malformations also. And the management is always surgical removal. You can have a partial agenesis of the upper vagina, where the segment of vagina is atretic in the upper third, and there is hypoplasia or absence of cervix. The uterus in this situation will be either normal or most often it is malformed. And the signs and symptoms may either present with primary amenorrhea, cryptominorrhea, hematometra, hematocolpos, cyclical abdominal pain, and abdominal mass. In this situation, hysterectomy conserving the ovaries, because when there is absence of cervix, then you cannot conserve the uterus. And in this situation, the treatment is always hysterectomy conserving the ovaries. ഞാൻ ഈ സെന്റൻസ് പറഞ്ഞു എന്ന് പറഞ്ഞ് പരീക്ഷയ്ക്ക് ക്രിപ്റ്റോമിനോറിയയ്ക്ക് ഹിസ്റ്ററക്ടമി മാനേജ്മെന്റ് ആരെങ്കിലും എഴുതി വെച്ചിട്ടുണ്ടെങ്കിൽ നോക്കിക്കോ. ആൻഡ് ഫെർട്ടിലിറ്റി, ഹൗ കം 98 സ്റ്റുഡൻസ് പെട്ടെന്ന് 91 ആയി? എനിക്ക് അറ്റൻഡൻസ് ഇപ്പൊ തന്നെ വേണേ. Fertility is achieved by assisted reproductive techniques and surrogacy. Just let me get a screenshot of the attendance and then we'll continue with the class. Okay. That. Okay. So I can at least tell madam that when we prepare class, this is the feedback we get from them. Okay. So the treatment options for vaginal agenesis is there no hormone replacement is needed because the ovaries are normal. Estrogen is produced normally, progesterone is produced normally. She only requires psychological counseling and non-surgical methods. Just excuse me, my slides have got stuck. Okay. So we will go to important short note for you, which is complete agenesis of the female genital tract, which you also call as Mayer-Rokitansky-Kuster-Horsten syndrome or Mullerian agenesis. Here, typically, the phenotype will be a XX karyotype. Phenotypically, she'll be a female. Genetically, she'll be XX karyotype. She will have normal gonads. She will have normal height. And she will have normal secondary sexual characters because the ovaries are not at fault at all. The ovary is the endocrine organ which is responsible for all the secondary sexual characters being developed. And normal ovulation takes place because she has normal ovaries. What occurs here is in agenesis or hypoplasia of the uterus, cervix, and vagina. The external genitalia may appear normal, but the vagina may be short and blind, because the part developing from the urogenital sinus will be developed and the part from the Mullerian ducts will be underdeveloped. This is most often associated with urinary tract malformations and skeletal malformations. So whenever you have an anomaly in the genital tract, you always have to look out for the possibility of urinary tract malformations as well. So this is the condition called as Mullerian agenesis, in which all the secondary sexual characters are normally present. The gonads are normal. The phenotype is like female, and she presents with agenesis or hypoplasia of the uterus, cervix, and vagina. This may be of varying degrees. It may be associated with urinary tract malformations and skeletal malformation and presents with primary amenorrhea. What are the treatment options available? No hormone replacement treatment is needed because she already has normal ovaries, which is providing the endocrine support. Again, she needs psychological counseling because she is having primary amenorrhea. And what could you do for her? Because the uterus is not developed, you can only prepare her for sexual function by non-surgical methods using vaginal dilators and surgical methods in which you can construct the vagina artificially by vaginoplasty. The different types of vaginoplasty are the McIndoe-Reed's procedure, in which a new vagina is created in the space between the bladder and rectum using a split thickness skin graft on a mold. And Williams vaginoplasty is a vaginal pouch created from the skin flaps of labia minora in the midline, which is not done nowadays. Vaginoplasty can be done with amnion graft as well. The complications for these surgeries are vesicovaginal fistula, rectovaginal fistula, infection, bleeding, rejection of the graft, all this restenosis and dyspareunia can occur. So usually, whenever a girl is diagnosed with Mayer-Rokitansky-Kuster-Horsten syndrome or Mullerian agenesis, we assess the vaginal length. And just before she is of marriageable age or she is getting married, we will think about doing a vaginoplasty for her. Doing a vaginoplasty very early will be of no use for her because, again, it will go into restenosis and dyspareunia. So, developmental anomalies of the vagina, I had already discussed. She can present with a non-canalized vagina in which total agenesis is there, as in the case of Mayer-Rokitansky syndrome. As you see here, There can be a partial agenesis, a non-canalized vagina has in this situation, where the agenesis is occurring quite high up. Or she can present with an imperfect hymen, or she can present with a transverse vaginal septum, or she can have a longitudinal septum which is communicating with outside, or she can have a fused longitudinal septum. Imagine this fused, the blood can collect in this situation, whereas here through this vagina, the blood can come out. So she can have a vaginal, longitudinal vaginal septum which is fused on one side as well. So till now what we were talking about was the causes of primary amenorrhea with normal secondary sexual characters. Can somebody just summarize what we learned till now? Yes? Anybody volunteering to tell what you just heard? Are you ready? Shall I pick up? Soumya Susan Toms.
Hello, ma'am.
Yes. Yes, Soumya.
Mullerian agenesis.
Just what we heard till now. First, we heard about the
Primary amenorrhea
definition of primary amenorrhea. I hope that is clear to you.
Yes, ma'am.
Then, how do you classify primary amenorrhea?
With the development of secondary sexual characters, without the development of secondary sexual characters,
and with the heterosexual development. Okay. Sedu Lakshmi, you are there?
Yes, ma'am.
Okay. Can you just tell me what are the causes of normal pubertal changes and primary amenorrhea?
Primary amenorrhea can occur because of androgen insensitivity syndrome, Mullerian agenesis, or PCOD, or stress, or very.
See, Sedu Lakshmi, just now I തുടക്കത്തിലേ ഞാൻ പറഞ്ഞതാ പ്രൈമറി അമിനോറിയ എന്ന് പറയുമ്പോൾ ആദ്യമേ കോസ് കയറി PCOS പറയരുത്. Primary amenorrhea with normal secondary sexual developments എന്ന് പറയുമ്പോൾ മിക്കവാറും എപ്പോഴും it is anatomical defects. So start off with what? Mullerian agenesis, androgen insensitivity syndrome, and the causes of cryptominorrhea. What are the main causes of cryptominorrhea?
Imperfect hymen, transverse vaginal septum.
Okay, vaginal agenesis, transverse and longitudinal septums. Okay, Mohammed Jamshir, you are there? Mohammed ille? Undanno illenno? Salmanul Islam. Illa. Rajat undo?
Yes, ma'am.
Just give me a brief idea about Mullerian agenesis.
It is phenotypically female, XX, normal ovulation.
The genotype, okay. The karyotype is XX. Then
ovulation is ovaries are normal.
Ovaries develop normally, okay.
But there is agenesis and hypoplasia of the uterus, cervix, and vagina.
It could be uterus, varying levels, uterus, cervix, and vagina. The girl presents with primary amenorrhea
and normal secondary sexual characters.
Okay. And
treatment psychology.
How do you diagnose it? Absence of
vagina.
Absence of uterus.
Uterus.
And how do you say whether there is uterus or not? What is the test which we do? Clinically, you do a per rectal examination. The per rectal examination, if the uterine body is not felt, and again you confirm it with ultrasound scan. So if the uterus is absent, it is
agenesis.
Mullerian agenesis, and it is also known as
Mayer-Rokitansky
Custer-Hosner syndrome. Very good. Okay. So now we go to the second half. Then there is another condition. It's getting stuck in between. Okay. Now I come to the hypogonadotrophic hypogonadism. Here, the gonads are not developed properly. It may be either because of increase in the FSH levels or decrease in the FSH level. So what conditions cause hypogonadotrophic hypogonadism? Hypogonadotrophin, which we mainly mean is FSH hormone, FSH and LH hormones. So in this situation, the hormone levels of FSH and LH are reduced. And what conditions cause this type of primary hypogonadism is one, the CNS abnormalities like neoplasms like craniopharyngiomas, congenital hydrocephalus, post-inflammatory conditions, post-encephalitis, infiltrative conditions like histiocytosis, sarcoidosis, tuberculoma, isolated gonadotrophin deficiency as in Kallmann syndrome, or the olfactogenital dysplasia, late onset congenital adrenal hyperplasia, GnRH receptor defect, LH and FSH beta subunit gene defects, miscellaneous like Prader-Willi syndrome, genetic causes, Lawrence-Moon-Biedl syndrome, chronic diseases, endocrine problems, severe weight loss, and psychosis. But there are so many umpteen number of causes causing hypogonadotrophic hypogonadism. അപ്പോൾ എപ്പോഴും നമ്മൾ എങ്ങനെയാണ് ഓർക്കുന്നത് hypogonadotrophic hypogonadism വരണമെങ്കിൽ cause എപ്പോഴും എവിടെയാ it is above the look into the slide. It is the ovaries. Ovaries are what? Not at fault. It is the LH and FSH is reduced. So if LH and FSH has to come, the hypothalamo-pituitary axis has gone into failure. So there is some pathology in this area. And that is the reason why LH and FSH is not sufficient. And that is causing the hypogonadotrophic hypogonadism. Clear? So there are umpteen number of causes, as we said. So CNS abnormalities can be there. There can be isolated gonadotrophin deficiency. And Kallmann syndrome, you must have heard about it. It is seen more commonly in males. There is olfactogenital dysplasia. They usually present with anosmia, hypogonadism, and color blindness. Okay. And they may have other features like cleft lip and palate and all associated with it. Okay. Then other genetic factors. So these are some of the causes of hypogonadotrophic hypogonadism. In all these conditions, the diagnosis and treatment is based on a detailed history and examination depending upon the condition. You have to image them, you have to do a karyotype. How do you manage them? You manage them with estrogen therapy. And fertility is always by ovulation induction with gonadotrophins, because you expect the ovaries to be normal in this condition. Okay, hypergonadotrophic hypogonadism. The other set of conditions which cause hypogonadism is the hypergonadotrophic. If you check the FSH LH level, FSH will be very much elevated. And what are the conditions which causes hypertrophic hypogonadism is Turner's syndrome and mosaic Turner's. Then you have the pure gonadal dysgenesis like XX and XY gonadal dysgenesis. XX gonadal dysgenesis or the pure gonadal dysgenesis also known as Perrault syndrome, and XY dysgenesis is known as Weier's syndrome. Fragile X syndrome, infections like mumps and pelvic tuberculosis, galactosemia, iatrogenic post-surgery, radiotherapy, chemotherapy, polyglandular autoimmune syndromes, enzyme deficiencies like 17-alpha hydroxylase deficiency, aromatase deficiency, Savage syndrome, and other idiopathic causes may result with hypertrophic hypergonadotrophic hypogonadism. And if you do the karyotype in the case of a gonadal dysgenesis, you can have something known as, you can have Turner syndrome in which it is 45XO, You can have a mosaic turner in the form of 45XO or 46XX, 45XO and 46XY, and you may have X chromosome deletions, 46XXP deletion, 46XXQ deletion. You can have pure gonadal dysgenesis as in the case of Swyer syndrome and Perrault syndrome. So you can have a short note question on Turner syndrome. So just to understand what Turner syndrome is. Turner syndrome is a karyotype abnormality. Phenotypically, they appear like girls, and the condition is 45XO. And it may also present as a mosaic pattern of 45XO, 46XX, 45XO, or 46XY, 45XO. And the condition is seen in the incidence of 1 per 2,500 live-born girls. Typically, the phenotype will be short stature. There will be webbing of neck. There will be cubitus valgus, shield-like chest with widely spaced nipples, Madelung's deformity of the wrist, genu valgum. The girls may have associated cardiovascular anomalies like coarctation of aorta and bicuspid valves. There may be associated renal abnormalities. The girl may also present autoimmune hypothyroidism, and in some children at least, when they present in birth, they may have edema and cystic hygromas. The other clinical features of Turner syndrome are epicanthal folds, low set ears, high arched palate, no breast development, short fourth metacarpal, pigmented nevi on the body, hyperconvex nails, sensory neural deafness, diabetes mellitus, and other autoimmune disorders. So these are some of the stigmata of Turner syndrome. They are usually of short stature, low hairline, characteristic facial features, the epicanthic fold, the eyes, then webbing of the neck, shield-like thorax, then the coarctation of aorta, poor breast development, widely spaced nipples, shortened fourth metacarpal, elbow deformities, small fingernails, rudimentary ovaries or the streak gonads as we call them, and brown spots on nevi and no menstruation. How do you manage a Turner syndrome? Again, these girls, if they are identified early, they require estrogen therapy. And how do you give estrogen? Don't give high doses of estrogen. You start off with very low doses of estrogen, and slowly, when the development occurs for over 6 months, when the secondary sexual characters start developing, you slowly, when the breast starts developing, the pubic hair starts appearing, in that situation, you turn off to, you add on progesterone along with it so that menstruation can be initiated. In these girls, you can initiate menstruation by giving estrogen therapy first, followed by progesterone, because they have an intact uterus. So, and since these girls are also having associated height stunting of growth, they may require growth hormone therapy also. They may be having associated increased mineralocorticoids in circulation, and because of that, they'll have hypertension. So you may have to give them steroids to suppress the mineralocorticoids. And fertility in them is achieved by ovum donation, because they are having streak gonads and they may not have sufficient ovum follicles. So you have to manage the fertility by ovum donation, in vitro fertilization. Now we go into another common condition which we generally see in the OPDs, which we call it as androgen insensitivity syndrome. Previously, it was called testicular feminization syndrome, but now we don't call it that because it has some stigma attached to it, testicular feminization. So the better terminology would be androgen insensitivity syndrome. And it's basically X-linked trait in 2/3 of the cases, and rest of the 1/3 cases of AIS are generally mutations, de novo mutations. The basic pathology in this condition is absence of the cytosol receptor, which is necessary for the action of testosterone, and the karyotype is always 46XY in this condition. Okay, so androgen insensitivity syndrome are girls which have what 46XY. They have undescended testicles, androgen receptor is absent, so Wolffian structures don't develop, and the external genitalia is always of female. The breast may seem developed. Actually, these are very beautiful girls. They have normal secondary sexual characters developing because of the peripheral conversion of testosterone to estrogen. They have normal breast, they have sparse hair on the body, and they are generally said to be beautiful girls, but the karyotype is 46XY. The diagnosis is when you do a karyotype, you get a karyotype of 46XY. They may present in newborn children or in young age as inguinal hernia. So the swelling in the inguinal region may be the undescended testicles. And when you check the testosterone levels, they'll be in the male level. So management, usually because they appear as girls, they are generally reared as females. But always remember, they have to be, as soon as they attain puberty, the gonads have to be removed, because the gonads in these girls are actually the testicles. And testicles in the abdomen with high temperature is prone to become malignant. So there is a risk of malignancy, so and especially dysgerminoma. So as soon as a girl attains a sufficient height, when she completes puberty, the gonads have to be removed, and estrogens have to be provided to prevent osteoporosis. Regarding the vagina, for sexual function, the vaginal dilators or vaginoplasty can be done for maintaining the sexual function. And she has to be carefully counseled, because it's a very sensitive area to inform the parents and the child that they cannot have a normal uterus or childbirth possible. Okay. And so roughly, if we were to compare inheritance pattern in Mullerian agenesis, it is sporadic, and in androgen insensitivity syndrome, it is 46XY, it is X-linked. So most often it may be seen in the family. Then karyotype is 46XX in the case of a Mullerian agenesis, and it's 46XY in the case of androgen insensitivity syndrome. Breast development is present in both of them. Axillary and pubic hair is present in the case of Mullerian agenesis, and it is absent in the case of androgen insensitivity. The uterus will be absent in both situations. The gonad is ovary in the case of Mullerian agenesis, and testicles is in the case of androgen insensitivity syndrome. So testosterone is female level in the case of Mullerian agenesis and male level in the case of AIS. Associated anomalies will be present. That is, the renal anomalies will be present in Mullerian agenesis. Generally, it is not seen in AIS. Then, as I said, there are rare causes of PCOS, of primary amenorrhea, like PCOS, hypothalamic dysfunction, and hyperprolactinemia. So, whenever you get a case of primary amenorrhea in the OPD, first you see whether she has normal secondary sexual characteristics or not. If she's having normal secondary sexual characters, you have to do an ultrasound to see for the presence of uterus or not. If the uterus is present, then it means she's having normal anatomy. So immediately look for the FSH, LH, thyroid hormone, and prolactin level. And all this will point out to diagnosis like early PCOS, hypothyroidism, hyperprolactinemia, and constitutional delay, depending upon the condition. If the uterus is absent, you have to do a karyotype, and if it is in 46XX, it is Mullerian agenesis, and if it is 46XY, it is a androgen insensitivity syndrome. Whenever there is an absence of secondary sexual characters, immediately you have to go for a hormone level estimation, like FSH estimation. When you do an FSH, if it is low, you have to think about the possibility of the hypogonadotrophic hypogonadism and go ahead with other investigations like prolactin, thyroid, ACTH, and GH. If everything is normal, it could be Callman. If everything is low, it could be a hypothalamo-pituitary failure. Then, if the value of FSH is very high, it points to hypergonadotrophic hypogonadism. Here, you have to go for a karyotyping. And if it is XX, it could be a what? Pure gonadal dysgenesis, or it could be a resistant ovarian syndrome. And if it is XY, it is a Swyer syndrome. And if it is 46XO, it's a Turner syndrome. Is it clear? Is it clear? Should I repeat the slides once more? Okay, shall I tell a few case scenarios which you'll be able to answer or not? We'll see. Okay?
Yes, ma'am.
Let me get one person. അതാ പിള്ളേര് കുറഞ്ഞു 86 എന്തെങ്കിലും അത്യാവശ്യ പണിയുണ്ടോ എല്ലാവർക്കും? കഷ്ടപ്പെട്ടിരുന്ന് ക്ലാസ് കേൾക്കുന്നതാണോ? വീട്ടിലെ പണികളൊക്കെ മാറ്റി വെച്ച് മുഹമ്മദ്മാർ ആരും ഇല്ലേ ക്ലാസ്സില്? മുഹമ്മദ് മുഫീദ്, മുഹമ്മദ് മിദ്ലാജ്, മുഹമ്മദ് ഉവൈസ് ആരും ഇല്ലേ?
Yes, ma'am.
ആരാ?
Mohammed Uwais.
Okay, so I'm going to ask you a question.
Okay.
I have a girl. She is 13 years and she has come to the OPD with complaints of cyclical abdominal pain. The parents have not thought about menarche or menstruation because she's only 13 years and she's complaining of cyclical abdominal pain. And because of the abdominal pain, when they went to a GP, the GP did an ultrasound scan and found out that she's having a ovarian cyst.
Okay.
Okay. So what is your provisional diagnosis? What would you do? What is the first thing which you would do for her?
Confirmed it has to be testicular.
I said very clearly, a simple symptom I gave you, cyclical abdominal pain. So whenever you have a girl like this, first thing which you should do is, you have to see if she's having secondary sexual characters developing. In 13 years, you cannot expect lots of changes, but if yes, secondary sexual characters will start developing. You have to palpate the abdomen to see if there is any mass. Okay.
Okay.
Right? And
Yes.
local examination, that is the most important thing which you have to do in this situation. When you do a local examination, what is the finding which you expect? Neetu?
Yes, ma'am.
What is the finding you expect here? Real life
There is
cases I'm telling you.
imperfect hymen, bluish,
You
bulging
can expect a
hymen.
dense bluish hymen, and your diagnosis will be imperfect hymen with, and what was the ovarian cyst? That was actually a backflow of the blood from the hematocorpus, hematometra, hematosalpinx, and into the ovaries. Okay. So that was it was not actually an ovarian cyst. It is the backflow of the blood from the hematometra, hematocorpus, and hematosalpinx into the sides of the ovaries. As hematosalpinx it is presenting. So it was mistaken to be an ovarian cyst. It was not an ovarian cyst actually. Okay. So what is the treatment for this girl which you will give? I'll ask Matthew George. What is the treatment for imperfect hymen? Matthew absent mark chedo. Shahana.
Hello, ma'am. Hello, ma'am.
Undo. Matthew undo.
Undo, ma'am.
Para.
Yes, ma'am. Ma'am, cruciate incision on the hymen.
Very good. A cruciate incision onto the hymen, and don't give any pressure on the abdomen. You allow the blood to drain on its own. Okay.
Yes, ma'am.
And what else? Yeah, what is the other thing you have to? You should not do what is the other important measure you have to take to prevent infection? Should not do a pervaginal examination.
Pervaginal.
Okay, you allow the tarry blood to escape on its own, and always put her on antibiotics. Okay.
Yes, ma'am.
Okay. Then I give you another real life question. Okay. I have a woman who has come to the OPD at 18 weeks of gestation, and her uterus. ആരാ സംസാരിക്കുന്ന ഒന്ന് മൈക്രോഫോൺ സ്വിച്ച് ഓഫ് ചെയ്യോ? ഞാൻ പേര് പറയുന്ന ആൾ പറഞ്ഞാൽ മതി ആൻസർ. I have a girl who I have a woman who's primary gravida, and she has come to the OPD with an ultrasound saying that the fetus is having a cystic hygroma. So the doctor does an ultrasound, fetal medicine expert does an ultrasound, and looking at the cystic hygroma at 18 weeks, they have done a karyotype for the fetus. What is the possible karyotype you expect in this situation? Not necessary, it should always be like that. But in the context of primary amenorrhea, when I said about cystic hygroma, which condition did I talk of? Yes, I'm going to ask Sheetal Sebastian.
Yes.
Now, what might be the karyotype in this fetus with cystic hygroma? Which condition did I say may present? ഞാൻ presentation പറഞ്ഞപ്പോൾ ഞാൻ പറഞ്ഞായിരുന്നല്ലോ, may present as cystic hygromas. ആര് പറയാൻ പോകുന്നു? ആരാ പറയാൻ പോകുന്നത്? നവനീത കേട്ടായിരുന്നോ? മറിയ കേട്ടോ?
Ma'am, Turner syndrome.
Turner syndrome. അപ്പോൾ karyotype എന്തായിരിക്കും? Most often it will be 45. പറ പിള്ളേരെ. 45?
XO.
45XO. Who said that?
Maria, ma'am.
Maria. Okay, good. So can I give you another case now? Shall I? These are all real life cases. Shall I tell you another case? Can you try to arrive at a diagnosis? Respond able.
Yes, ma'am.
Okay. So I have two sisters brought to the OPD with complaints of primary amenorrhea. The elder one is 18 years and the younger one is 16 years. And they have been locally seen by so many doctors, some investigations done. And because of their poor economic financial constraints, they have not gone much into investigations and all. And they have brought to the OPD as primary amenorrhea. Both of them are very beautiful girls, tall, with sparse hair, tanner, breast development is tanner, stage 3. Then they have sparse pubic hair, sparse axillary hair. And when I palpate both of them, one of the girl gives history of a swelling in the inguinal region being removed at 1 year of each. And the elder one. And both of them on examination do not have uteri. When I do a rectal examination, both of them don't have a uteri. And when I do an ultrasound also, they don't have uteri. And they are having gonads. The normal gonad is noted in one, and the other one is having only one gonad. The other one is removed as an inguinal swelling in a young age. Okay, so what? And both of them have blind ending, small vagina. So what could be the diagnosis? Srikanth. What are we talking about? Srikanth ille?
Yes, ma'am.
കേട്ടോ കേസ് പ്രസന്റ് ചെയ്തത്? കേട്ടോ ശ്രീകാന്ത്? കേട്ടില്ല. Who is going to volunteer? ആരും വോളണ്ടിയർ ചെയ്യാനില്ല?
Ma'am, androgen insensitivity.
Yes. So typically X-linked, it runs in families. There is an absence of uterus. As I said, they are tall. So what is the main issue with these people? They have to be properly counseled. And who said the answer?
Adisri.
Sorry?
Adisri.
Okay. So what is the main important thing which you have to remember in this situation? You have to remove the gonads. You have to remove the gonads as soon as they have attained sufficient height. Why? What is the risk of this? What is the risk of keeping the gonads?
Malignancy.
They can turn into dysgerminomas. They can become malignant. because of the intra-abdominal location of the testicles. The gonads are actually testicles in this situation, so they can become malignant. So in order to prevent the possibility of malignant, they have to be removed. And how do you protect the bones and all for future? By giving them estrogen. Okay. So shall we call it a day? Thank you.
Thank you, ma'am.
Thank you.